When the concentration of glucose in the bloodstream exceeds physiological limits, the environment turns toxic. These jagged particles accumulate along the vessel walls, creating a physical drag that slows blood flow to a crawl. Clinical medicine categorizes the various metabolic disorders causing this state as diabetes mellitus. While their origins differ, they are united by the same destructive condition: chronic hyperglycemia. To understand how to arrest this process, we will track the disease from its physiological baseline through its pathological failure, diagnostic detection, systemic complications, and pharmacological management. This chronic elevation of blood glucose results from an underlying genetic predisposition triggered by environmental influences like diet and sedentary lifestyle. The global impact is staggering. The sustained metabolic failure increases morbidity and the necessity for surgery, placing immense economic strain on healthcare systems. The primary clinical challenge is the disease's silence. In type 2 diabetes, a decade of biological damage typically occurs before the patient ever receives a formal diagnosis. This delay allows for a creeping systemic breakdown. The body's infrastructure erodes in the background, often remaining invisible until the structural damage to the organs is already well advanced. Normal glycemia relies on a precise equilibrium. The glucose entering the blood from diet and liver production must exactly match the amount consumed by the cells for energy and storage. The body manages this balance through a hormonal seesaw, constantly weighing regulators that increase blood sugar against those that lower it. Hyperglycemic drivers sit on the right side. Glucagon, cortisol, and catecholamines increase glucose production, ensuring fuel during fasting or stress. Opposing all three is one hypoglycemic hormone, insulin. It lowers blood glucose by facilitating its entry into target tissues. Insulin is synthesized within pancreatic beta cells, starting as pre-proinsulin, which cleaves into proinsulin. Proinsulin then splits into active insulin and C-peptide. Co-released in equal amounts, C-peptide is a crucial clinical marker measuring a patient's internal insulin production. The entire human metabolic engine depends on the production and cellular acceptance of this hormone. Without it, the entire system loses the ability to process fuel, shifting immediately into a state of metabolic crisis. We identify two primary points of failure in the system. Type 1 is an autoimmune collapse, while type 2 is a progressive resistance to the insulin signal. In type 1 diabetes, an autoimmune strike destroys pancreatic beta cells, causing absolute insulin deficiency. Blood sugar climbs to extreme chronic hyperglycemia. Desperate for fuel, the body breaks down fat, releasing fatty acids that become acidic ketone bodies, risking life-threatening diabetic ketoacidosis. Type 2 diabetes begins with tissue resistance. Muscle, liver, and fat cells stop responding to insulin. The pancreas initially compensates by overproducing it, causing hyperinsulinemia. Eventually, beta cells exhaust themselves, causing a relative insulin deficiency that cannot overcome tissue resistance. Type 1 is a rapid destruction of the insulin factory. Type 2 is a slow burnout caused by the cell's inability to hear the factory signal. Because the biological symptoms of this failure are often invisible, diagnosis depends on standardized biochemical tests that measure the persistence of high blood sugar. Full diabetes requires meeting diagnostic thresholds: fasting glucose of 1.26, a tolerance test of 2.00, or an HbA1c of 6.5%. We also monitor prediabetes, the high-risk intermediate state. However, without clear symptoms, a single abnormal test isn't diagnostic and requires confirmation. A random glucose reading of 2.00 or higher is only diagnostic if it coincides with classic symptoms like polyuria or rapid weight loss. Strict adherence to these biochemical thresholds is the only way to catch the disease early enough to prevent irreversible organ damage. Sustained high glucose physically degrades the body. This damage presents in two forms: acute metabolic emergencies and chronic vascular erosion. Acute emergencies are immediate. Diabetic ketoacidosis is driven by insulin lack and the presence of ketones, while hyperosmolar hyperglycemic state is a crisis of extreme dehydration and glucose elevation seen in type 2 patients. A third acute risk, hypoglycemia, occurs when an excess of insulin or medication drives blood sugar too low, depriving the brain of necessary fuel. Over years, glucose bonds with proteins, forming advanced glycation end products, triggering oxidative stress that strips blood vessel linings. This causes microvascular damage, retinopathy, nephropathy, and neuropathy, and accelerates macrovascular complications like cardiovascular disease and ischemic strokes. Chronic hyperglycemia acts as a slow-moving solvent, gradually eroding the structural integrity of the entire human vascular system. To halt this cascade, clinical management uses a sequential approach to lower glycemia and protect the vascular highways. Management begins with lifestyle, nutrition, exercise, and weight reduction to reduce insulin resistance. Pharmacological therapy follows. Type 1 requires lifelong insulin, while Type 2 uses a progressive ladder of oral drugs, like metformin, before advancing to insulin. Prevention is highly effective for Type 2, where modifying risk factors can stop the disease cascade. However, there is currently no established lifestyle prevention for the autoimmune strike of Type 1. Effective management relies on structurally aligning the patient's metabolic inputs with their compromised processing capacity. Diabetes mellitus is a failure of glucose homeostasis. It stems from the destruction or dysfunction of pancreatic beta cells, leaving the body unable to manage its primary fuel. Left unchecked, this leads to profound, irreversible damage across the micro and macrovascular systems. Early detection, rigorous glycemic control, and intensive patient education are the only definitive ways to arrest this cascade and preserve the patient's quality of life. Understanding the mechanisms of this failure is the most important tool we have in preventing its outcomes.